interesting that Liam gave me history in the title of the talk. So I was presenting at the 8th Biennial World Congress of Alcohol and Drug History, which you think is rather esoteric. However, what I hadn't known, and some of you may know, is the area I was in Ohio and other northern states in the United States are in the grip of a heroin epidemic. And if you watched, and I'm sure you can get it on ITV Online, the 10-15 minutes that were in the On Assignment program that was shown last night on STV, you saw towns, and this is middle America, middle-class white youth of middle America, using heroin in an uncontrolled way in a system that doesn't have opiate replacement therapy to speak of. And there was footage last night of someone walking down the street, openly injecting drugs, heroin into the back of his hand, for example. And the Centre for Disease Control this year, this is also in the current edition of Time magazine, is having to respond to HIV and HCV local epidemics on the back of this increase in heroin. Hopefully it's a place that we won't go in Scotland. And I hadn't fully understood it. I knew in America there had been a problem with uncontrolled prescription painkiller misuse. So people under 40 in America getting put onto oxycodone, and a very steep rise in the use of these powerful opiates, so that's the tablet on the hook here, was hooking in these younger people, and then doctors got cagey about continuing to prescribe, so stopped the oxycodone, and people turned to the black market and turned to IV drug misuse and heroin. So very, very scary. I think we can thank our lucky stars that we do have opiate replacement therapy, that heroin use seems to be plateauing or falling, new initiation in Scotland, because certainly this seems to be fueling increased HCV and HIV at the current time. So just as an aside, you might want to look that up. So it was more than history in Bowling Green. It was current concern, across the Atlantic. I think history is very important to what I'm going to say here. I work in this unit, so I'll tell you a bit about its history, because it's the history of addiction specialism in Scotland. So this unit has a history going back to the early 1970s. It sits in a general psychiatric hospital, and it was built, it was at one point called the Alcohol and Drug Treatment Unit, the Alcohol Problems Treatment Unit. Its name has changed over the years, but it was built in response to the recognition that more people with alcohol problems were coming into general psychiatric wards in the 1960s and the 1970s with suicidal depressive crises. So addiction psychiatry, as we have it within the NHS in Britain and within Scotland, grew up in the more recent times in response to a rising alcohol problem within UK Scottish society. And the idea was to give specialised treatment for alcohol dependence, and then laterally when heroin came as a problem, we developed systems there around detoxification from heroin. Now I am becoming history, I think, because I'm old enough, and I can actually, my practice started in addiction psychiatry in the late 1980s, and predated an effective methadone system in Glasgow. Interestingly, in Glasgow, we had another attempt, a previous attempt with methadone that was abandoned, and people thought methadone didn't work. There was a psychiatrist called Dr. Paddy Mullen. He used methadone. He decided it was ineffective, unsupervised methadone, and wrote about this failure in the British Journal of Psychiatry. And the key when the heroin epidemic came was, of course, supervision of methadone. But the delivery in Glasgow, unlike the rest of Scotland, came through general practice mainly. So there was a bit of a disconnect. Addiction psychiatrists early on in Glasgow didn't pick up the opiate replacement therapy strand. Kershaw Unit, as it currently exists, has 20 inpatient beds, has a 7-day-a-week day hospital. It's serving a population of about 750,000 catchment area. It's offering detox from alcohol, it's offering detox from drugs, it's offering mental health assessment for people with addiction problems, psychosocial interventions. For people with the most severe conditions, of course, the addiction system in Glasgow also has a community arm. So the methadone clinics are based in community addiction teams, which are generic and are dealing with both alcohol and drug problems. But the history is such that I think investment was very much ring-fenced. So we developed alcohol services, and then we developed separately drug services. And in places then there's the problem of coordinating, because sometimes you can have the issue of, oh, here's someone on methadone, they've developed an alcohol problem, they're Hep C positive, what do we do about the alcohol problem? Oh, we need to refer them to another clinic that deals with alcohol. Whereas we need to somehow solve that problem as far as we can and think about a one-stop shop. Just as we're trying to move hepatitis C treatment as far as possible, perhaps into the ORT clinics. You know, our clientele often don't like going to multiple clinics for treatment, so the more we can bring this together in one place, the better. So clinics like this should be multi-functional. Just to remind us about alcohol, because we're hearing a lot about how alcohol is fueling the rise in liver disease, how important it is for HCV infection as a component of the move to end-stage liver disease. We have been living in an era of rising consumption, but if you go far enough back in Scotland, the problems were even worse. I heard Sir Harry Burns speak recently, and he told the audience that Scotland, in this point in the graph, Scotland used to be, in living memory, quite a sober place. And it is true, in the 1930s, a parliamentary committee said that the English need to learn from the Scots in their sobriety in a review of liver disease. The problem is, and Sir Harry probably knew this, but it was just trying to remind us things aren't static. You know, our drinking culture needn't be what it is. In the 19th century, we were particularly drunken. And this led, this is a historian from Dundee, 2 summers ago. He published a very convincing article in History Scotland, 6 or 8 pages of historical research. The drunken Scot. Was Victorian Scotland the most drunken nation on earth? His answer was yes, from the data he had. And there's lots of statistics showing Edinburgh was 3 times as drunk as London in terms of drunken disorderly behaviour, and Glasgow was 5 times as drunken as London. So Glasgow outstripped Edinburgh. Things perhaps have got back to that, because Scots are drinking more than the English now, hence the increase in cirrhosis, more than in England. The Nielsen data showed us 11.5 litres of absolute alcohol per person per year in Scotland compared to, say, 10 in England and Wales. And if you survey people on the street in London, Glasgow, Edinburgh, it seemed the same. But when you actually got from the drinks industry how much we were spending on alcohol per capita, the Scots were drinking more. So we weren't being fully honest, or the people drinking more tend not to be stopped by people who do surveys on the street, perhaps. But, so this graph up here is to remind us at alcohol, so we're talking about alcohol, ORT, Hep C, and the other thing we mustn't forget is also mental health. So these are the top 10 risk factors for chronic ill health in Western populations, top 10 disease entities that lead to chronic ill health, and the relationship between them. Quite a complex slide, but I just want to highlight there's an arrow going between alcohol and unipolar depression. So depressive illness, the #2 reason for chronic ill health in our population. A DALY is a disability adjusted life year, and there's a strong relationship between alcohol consumption and levels of depression. And that also is the explanation to a large part of why the more a population drinks, the more suicide you're likely to see. Depressive illness causes suicide. Alcohol dependency has a high risk of suicide, not necessarily with depression, but there is an intermediate stage where alcohol misuse can cause depression and suicide. So also people in ORT can have increased depression. Often our patients who are HCV positive struggle to know whether their tiredness is down to depression or down to the virus. So you have this complex mix of conditions that you're trying to tease out what's at play with the individual patient in the clinic. Just as, I don't think we've had that slide, although I was a bit late in, but just to remind us the Lee and McCambridge slide from the Lancet. So this business of why is Scotland out of step, the Nielsen data goes some way to explain that, HCV goes some of the way to explain that, obesity goes some of the way to explain that, and the strong association with liver death, and which I don't think is fully explained, but maybe to do with polarization of drinking behaviour in the poorer communities with deprivation indices. So it's particularly men in our lowest socioeconomic groups in Scotland who are dying, as the deep end GPs talk of, young and yellow. So what is this deprivation index? Talk of the Glasgow effect and so on. I don't know if we fully understand that. It's said that all these risk factors don't necessarily explain the excess mortality. So why are we drinking so much? The average patient attending the Kershaw Unit, Jan Gill and her colleagues have shown in research leading up to the hope for minimum unit pricing, which we're still awaiting, but watch this space over the summer, European courts, etc. And SHAAP, who I'm here on behalf of, we're campaigning strongly for minimum unit pricing, and a lot of our work is in Brussels and in Europe at the moment to try and get the Europeans to allow us to have minimum unit pricing in Scotland, which is badly needed. My average patient at the Kershaw Unit with an alcohol problem, with or without comorbid opiate dependence, with or without HCV, is spending 21 pence a unit on alcohol. And that is either your Frosty Jack cider, new one to me, but it's creeping in, the K cider, and your supermarket own brand vodkas. You can get at that level. Cheaper in water, as the Sunday Mail helpfully told us. And another way of showing you that relationship with deprivation in Scotland having excess mortality from liver disease in UK terms, so alcohol-related deaths are predominantly liver disease. We've been doing research into this in Glasgow, looking in detail at case notes of those who died through alcohol-related death according to the General Registry of deaths. But this, as Penny McCaskill once said, is the red face of Scotland. The Kershaw Unit serves 3 different local authority areas that are number 1, 2, and 3 for alcohol-related deaths in men for the whole of the United Kingdom. You have to get up the league table. Interestingly, Blackpool is very few places outside of Scotland. West Belfast and Blackpool. A lot of Scottish people in Blackpool are holidaying in Blackpool, perhaps. Anyway, so 15 of the 20 UK areas with high male death rates from liver disease in Scotland. and also for women. So our politicians are responding to the alcohol component of this concern about rising liver disease. And we have had more investment in specialist treatment. Addiction nurses going into the general hospital has been a major area of growth, both around alcohol and drugs, so they're generic, so they're able to respond. They could deliver the brief interventions for someone who is on ORT but is drinking to excess and is in a liver ward, say, and they are doing that kind of work. I mean, I'm not sure we know the split in their work particularly well, although often they do good research in what they're doing. I probably should know more about that. We have put our money where our mouth is in Scotland by reducing the drink drive limit, and the biggie, of course, would be minimum unit pricing. And there's no doubt that that would work if we had 50p a unit compared to 21p a unit. Potentially, our patients might halve their consumption overnight. And there's evidence that they don't necessarily move to other intoxicants, and they don't necessarily find a way to get alcohol. They don't all take up home distilling or get hold of methyl alcohol by mistake, etc. And there's good evidence. So the history conference I was at touched on that as well, historically. Prohibition in the United States, for example, people didn't necessarily move to other drugs. Of course, there has been a downturn, austerity, people having less money to spend, some increased taxation. Some of these measures in the Scottish Alcohol Action Plan have come into play. So we are seeing some hopeful signs, but not enough from what we've heard today. I won't dwell on this because I was trying to work out how much of these liver deaths that are alcohol might hit Hep C. So I was looking at some of David Goldberg and colleagues. Also mentioned, these new antiviral drugs, very expensive. How much are they going to be cost effective? Can we say that when we're so awash with alcohol is an interesting question. Would we be better spending that money on better alcohol prevention and treatment? I think might be something we come to discuss. How are we going to deal with that? Interestingly, also from the Time magazine, one thing they do in the United States is advertise directly to patients. So in here I found an advert for I'm ready to be hepatitis C cured. So straight to the patient, and you need to ask for Harvoni, a breakthrough treatment for chronic Hep C, genotype 1 in adults, in my Time magazine. And I think that this is going to be complex for us, because I had a patient last week tell me he'd been to the Hep C clinic. His liver disease isn't particularly advanced. He did have a major alcohol dependence problem. He's staying off. He was being offered interferon, pegylated interferon and ribavirin. He had looked up online and saw one of these expensive new drugs might be better for him. And he was being told, no, you can't have that, it's too expensive, it's not approved yet within our protocols. So he came to me and he said he had a strong urge to start drinking again because he thought that might then prioritize him for the drug if he could move his liver disease on a stage. Now, a very, very odd discussion. I'm going to look into it. I'm not quite sure what. I'm going to have a dialogue with the hepatologist and just see what's going on with that individual patient. But it underlined to me just how much we're all going to have to learn and coordinate around individual patient care. So I think this paper, Innes et al., was saying something similar to what we heard from the French data. So I work in Great Glasgow and Clyde. So these are figures from March 2013. We've got 9,362 people in our system on opiate substitute treatment. A high number of these HCV positive, high number of these comorbid alcohol use disorders. And I think we are starting to learn how better to address comorbid alcohol problems. Our community addiction teams are investing more in alcohol treatment and having specialised teams within the generic community addiction team. And it has always been open for referral within, so there are Tier 3 services up to the level of the Kershaw Unit, Tier 4. So in terms of my own history as a clinician, I am seeing more patients with liver disease. I'm seeing more patients initiated on methadone who then became alcohol dependent as the years have gone on. But of course, there are more people on methadone. When I tried to look at this literature, I thought that there was maybe an established thing that once you stabilize away from heroin, you seek other intoxicants. The best review I could find suggested 3 papers found that going on methadone, your alcohol level of intake increased. 3 actually showed alcohol went down, and out of 9 papers, another 3 were neutral. And there was 1 paper, hence my question to the French specialist, about buprenorphine compared to methadone. Maybe people on buprenorphine drink less than methadone. But again, I think there's so much that we don't know. But we know the numbers out there that we're trying to target between these three groups. I think we're lucky in Scotland, as we heard earlier, that we have such good data on HCV and such good epidemiology, along with Denmark. But I think many countries, am I one of the few who, in Bowling Green, Ohio, I heard for the first time PWID, and I had IVDM, IVDA. So in the last week, I have learned about people who inject drugs, and PWID is the new acronym. I can admit my ignorance. And in America, they're also speaking about PWD, people who use drugs and people who inject drugs, and talked about this person-centered language. So I think it is a good term. We need, in other countries, splicing it out, we're saying we need to know more about this. But undoubtedly, we've established there is a problem. I think this has already been said. So, basics, you've got to ask, do you drink? How much do you drink? You might use the audit, you might use an alcohol use disorder identification test. We're going to go on to discuss brief interventions if the person's drinking too much. Of course, with HCV, probably the recommendation is don't drink at all. But if you're going to drink as little as possible. So brief interventions, and if there's dependency, if there's a need for detox, refer on. Don't have time to go into it, but the other complicating factor in terms of comorbid addictions, we heard about smoking, but the other one that's surrounded Scotland, of course, is benzodiazepines. So it's not an uncommon situation. Alcohol, street Valium, stabilized on methadone or almost stabilized on methadone, HCV positive. Can you detox? But when you're detoxing, you're not just detoxing from alcohol, and it makes it trickier. You can be detoxing from a high level of diazepam intake. And then the controversy of should we be maintaining some people on diazepam or not is a whole other area. I won't raise that thorny issue just now. Ideally in treatment, we want to do this. We want the person to become taller, a fine upstanding citizen. Now, where is this slide from? If you go to the Museum of People at Glasgow Green, People's Palace, this was someone who took the pledge to give up alcohol, didn't come near a doctor, and was abstaining from alcohol as part of the temperance movement. So this was education of the public. This could be Alcoholics Anonymous today, or Narcotics Anonymous, or someone undertaking through self-resolve to have abstinence. Hardly looks the same individual, but if you come to me as a specialist, I'm going to probably, if you're dependent, offer you detoxification. I'm going to offer you psychosocial interventions towards abstinence, which are evidence-based. If you're on methadone, of course, I'm not going to give you naltrexone because that's contraindicated, opioid blocker. But we might give you disulfiram. And there's an interesting question, and I know some colleagues around Scotland, if you're on supervised methadone, you've had a detox from alcohol, why not? If your liver's up to it and there are no other contraindications, also alongside that have supervised disulfiram. and it's going to keep you off alcohol if it works. Because if you drink on your disulfiram, you immediately become unwell. You know this, so you avoid alcohol. You're in the chemist anyway. Should we be maybe twisting arms for that? Would that be, to improve health, to keep people off alcohol where it's justified? So there are a lot of options, a lot of treatment systems, and as far as I can see, we're not excluding people on ORT with Hep C. They get referred. They've grown in number. Hard slide for you to see, but this is just a kind of medical slide, and I called this from an American document. But there's some medical complexities to, if I'm going to prescribe you antiviral drugs for Hep C, there are some drug-drug interactions that we have to be aware of. So we need to make sure that we're not giving a drug that's contraindicated. Zolpidem, for example, quite a common sleeping tablet in Scotland. So you might by giving some of these drugs actually reduce the effectiveness of drugs for mental health reasons, because they can reduce the concentration. By giving some of these drugs, you might have to increase the dose of methadone, for example, the antiviral drugs. So we need to be, the doctors involved need to be educated about this matter. So I don't know how I'm doing for time, probably just about spot on, hopefully. So I think today's great. I'm really enjoying being here. I'm learning a lot. And I think the paper in our pack, I'll be reading that very carefully, because I like the way it was set out, question and answer, and most of these questions were in my mind prior to today, and there's an attempt to answer those questions, and I stop there. Thank you.
Thank you.